Hi, everybody. Welcome back to the living room, part 2 of our 3-part AYA speaker series. We're very, very excited to have you, everybody in the room and everybody signing in online. Welcome, welcome. A big warm welcome to Dr. Geoff Oxnard, who this is his second appearance at the living room. We appreciate him flying all the way out from Boston. As you guys know, he is oncologist extraordinaire at the Dana-Farber, or the Farber, right? And we really appreciate him coming out. Thanks for coming again. What I'm gonna do tonight is we'll do the around the room. There's not so many people that we have to keep it just really quick. Hi, I'm Neil, and move on. But let's try to keep conscious of everybody's time, and then we'll jump right into the program. So, Neil, do you want to start since I said your name and was looking at you?
Hi, I'm Neil, and I'm going to yield my time so Joe and Nancy will have more of it.
Thanks, Neil.
That's hard for him.
I'm Andrea, and I work with the foundation, but I'm also Bonnie's daughter, and probably this is what interests me the most, based on our family history, and not only for my family, but for my future family, which hopefully will be a long time from now.
I'm Penelope, and I lost my mom to lung cancer at the end of 2013. Finding this organization was what helped us get through the time we did have with her. And she's one of 3 sisters who died of lung cancer, all non-smokers. So we really want to come to the bottom of this, and I'm worried for myself and the rest of my family as well. And yeah, and we love everybody here.
I'm Raymond, and my brother Stephen is been diagnosed recently with lung cancer, and this is my daughter Hannah. I'm her dad.
I'm Hannah, and my uncle Stephen was diagnosed with lung cancer, and I'm doing a school project on this organization.
Hi, I'm Patty Lundberg, and my husband had lung cancer about 8 years ago. We have 2 daughters that I'm very concerned about. There's been a lot of cancer in the family, so I'm here to learn more about heritability and just to get some support, and very interested in the topic.
Hi, I'm Sally. First of all, Hannah, I saw your presentation. It was fantastic. Very proud of you.
She did a great job.
And I am a survivor. Mine was found early. I'm adenocarcinoma, stage 1A. But my mother had it 3 times, believe it or not, over a period of 22 years. She had 3 separate lung cancers. The last one finally at 80, almost 86, did her in. Her brother had it, my maternal uncle, and my grandfather, my paternal grandfather, had it. So I'm very concerned about my family, but they don't seem to be concerned at all. They just want to ignore the whole story.
Yeah.
Thanks, Sally. I'm Scott Santarella. I'm the president of the organization. And Geoff, just so you know, Sally wanted to take you home last time you were here, so watch out later.
You take me to the airport. Hi, I'm Martin. My wife, sitting next to me, was diagnosed last July. And in the last 20, 30 days, I have a new wife with a great hairdo that I just love, and tell her it's thumbs up. Connections in addition to that are, of course, Sally, who I went to high school with. And more exciting than that is Danielle is going to speak to San Mateo Rotary this Thursday, of which I'm a 30-year member, and I'm so very excited to bring the foundation out in public in that venue.
Yes. Esty.
Esty.
I'm Esty Caldwell. My daughter had lung cancer. She lived in Golden, Colorado.
Hold it a little closer, Esty.
Oh.
There you go.
Golden, Colorado. And they treated her for colds and flus and allergies. And by the time they found out, she was in stage 4 and dying of lung cancer. And then I found out by insisting on an X-ray, which I had a physical 2 weeks earlier, and I was in perfect health, my doctor said. So I insisted on an X-ray, and they found, turned out I ended up with stage 1 lung cancer at the same time she was dying of lung cancer. So I'm trying to see if there's a connection between the fact that she had also, hers wasn't blanco alveolar, mine was blanco alveolar. Hers was I don't know, I can't think of what they called it, but same thing, non-small cell, lung cancer. So I'm curious, maybe there is a connection.
Esty, how old was she when she was diagnosed?
What?
How old was she when she was diagnosed?
I'm trying to figure it out, 28 or 29.
Yeah, she was young.
Yeah. She was young.
Yeah.
She was young.
Yeah.
Hi, I'm Kimberly Chapoister. I work here at the foundation. I lost my father to lung cancer in '89, and I worry about my family, me and my sisters, and of course we're all older now, but still I have that wonder, I have asthma, so I take inhalers and worry about lung cancer very much.
Do you guys want a mic? Is there a traveling mic for the back?
Yep.
Anyone? Oh, does Stephen have it?
Yeah.
I don't know. It's somewhere. Oh, there you go.
My name is Ren Long. Oh, thank you.
There we go. There we go.
My name is.
Uh-oh.
Hello.
No. Bueller.
Oh, now it's on.
Hi, my name is Ren Long Joe. This is my wife, Ian. I was diagnosed lung cancer with a squamous cell, third stage, last November. And at this moment, I've been told by the doctors in Stanford I'm supposed to be cancer-free now after the surgery, completely remove my left side of the lung. So I'm very, very curious that how did I get that, even I'm not a smoker, and how this genetic thing can impact my children or grandchildren. So very interested, look forward to this speech.
I'm Suzanne Roy. I work at Clovis Oncology, based in Boulder, though, and whenever I'm in San Francisco and you happen to have one of the living room sessions come in, I like to drop by. It inspires us, and I pass vignettes on to my team to keep us motivated and working.
Anybody in back?
Hello, my name is Yvette, and I'm here joining my mom. And my mom was diagnosed with stage 4 non-small cell adenocarcinoma in January of this year. And we're just here also. I just want to know, obviously, more on how does that affect us, the new generation, I guess, her kids, if this is actually something that's passed on or inherited. And obviously, I want to learn a little bit more. Thank you.
Thank you. Thanks, everybody. Jen, does anybody online want to say anything before we? Okay. Yes. Oh, yeah, go ahead, Stephen.
Hi, I'm Stephen Young. I'm the president of the Addario Lung Cancer Medical Institute. And Sally, we all want to take Dr. Oxnard home. So
Can I just say for a second that my grandfather died of lung cancer. He was a primary care doctor. He did house calls in Connecticut. He never smoked. That was just after I finished college and before I went into medical school. A lot of us have family histories of lung cancer. My grandmother, also a physician, one of the first female physicians back in the day, has smoked like a chimney all of her life and is lung cancer free. I mean, it's amazing how risk goes, and it's amazing who gets this disease. But I can resonate with a lot of what all of you have said.
I didn't know that. Interesting. Well, on that note, I think it's important to let you guys know who these lovely ladies are. Of course, everybody knows Bonnie, or Mom, as my sister and I call her. Most of you know Nancy, because she's been a long-time living room participant. There you go. I couldn't find the word. So some of you know her story. Those of you who don't, you'll be able to hear hers tonight. And then Jo. Jo is joining us tonight. She is a patient of Dr. Oxnard's, and she has flown all the way across the country to be here. So we're really, really excited and happy to have you. So thanks for coming. So I think we're going to start with something. We've talked to you guys a lot about Inherit and alchemy and some of the studies that we're running through the consortium. Inherit being one of them. Dr. Oxnard is leading. He's the PI for the Inherit study. So. The little bit you know about it, we're excited to be able to take it sort of a deeper dive, and we'll tell you about some exciting news about who else thinks that this is a pretty cool thing and what's going on with that. But let's start just with basics, and by basics I mean, what is T790? We talk about it a lot here, but what is T790?
Let's talk about genetics. Just like, what is genetics, right? Let's remember that there is the cancer's genes, and then there's the person's genes, right? The cancer's genes are different. The cancer picks up different alterations based off your own genetics, and those new genetic alterations the cancer acquires are what makes it think and what makes it grows. Cancer genotyping is so important. Don't guess, test, right? And if you're a cancer patient in the room, no matter what your histology is, squamous or not, I'm going to presume that you've had genetic testing of the tumor. Yes? Okay, good. Genetics is part of how we understand the cancer. And indeed, for my patients, if genetic testing is negative, dig deeper and look further. Because the more we look, the more we will figure out the signature that explains how the cancer thinks. One of those mutations that cancers have, most commonly they acquire this mutation, is T790M. Right? Cancer's genetics are dynamic. It can have one genetic signature today, and under the course of treatment, it can evolve new genetic alterations that explain how it's thinking tomorrow. And T790M is the most common resistance mutation that develops in lung cancer after treatment with drugs like erlotinib or afatinib or gefitinib. It is a resistance mutation. And in a patient who's been on one of these oral EGFR therapies for a year or so, half of them will develop this T790M, and that indicates certain clinical significance today because it means you might be able to develop, receive treatment with one of these new T790M inhibitors, like ruxolitinib from Clovis or like AZD9291 from AstraZeneca. That's what T790M is first. It is an acquired resistance mutation, T790M, which means at position 790 in EGFR, a T has become an M. Okay, fine. It's a resistance mutation. This mutation not only can occur under the pressure of treatment when the cancer, in response to treatment, genetically evolves, but it also can occur at diagnosis. All of you cancer patients who have had genetic testing at diagnosis know that it is possible to identify a signature, and that signature may be more or less complicated to identify. And it may be a common signature or a rare signature, and it may be an unknown signature that we cannot detect yet. But one type of signature, and in fact, 1 in 1,000 lung cancer patients at diagnosis, approximately, has T790M, a mutation in EGFR, a resistance mutation at diagnosis that shouldn't be there. Jo had this in her cancer. Why is this resistance mutation present at diagnosis before ever being exposed to a drug? That's the question we wanted to study in the Inherit study, to understand if this mutation that you see in the cancer that explains how the cancer is thinking and why the cancer is doing what it's doing is not in fact the cancer's mutation. Is it actually the person's mutation? Is it actually in the patient's genes and therefore has been transmitted to the cancer's genes, and the cancer is using it as part of its biology? So a mutation can occur in several ways. It can be acquired after treatment, it can occur at diagnosis, and it can occur in the patient themselves. It can be an inherited mutation. T790M can be any one of those three things. Does it answer your question?
Yeah, you did a really good job. It's so funny because as he's talking, I just keep thinking of all these great little clips that we can pull out of it to make, you know.
Okay.
You're doing it good.
Cancer evolves, and part of what cancer uses, it borrows from us, from the patient. And the question is, can we see into the patient's genetics by testing the cancer's genetics? And that's kind of a new question that's not been tested before, and that's what we're testing in this. Patients who have this in their tumor, not patients who have acquired it after treatment, but patients where it's there in the beginning, we say maybe it's there because it's in the patient's genes. And because this mutation is in the tumor, we then take their blood or their saliva on the study and test if it's in the patient as well to know if it explains how perhaps they got cancer in the first place.
So, Dr. Oxnard, is the T790 mutation on a standard lung cancer panel? So would every newly diagnosed patient be tested for that? And if not, when would they be tested for the T790 mutation?
Great question. A patient treated at our institution, a never smoker, young, showed up and had the standard testing for EGFR mutations. And the most common EGFR mutations, L858R and exon 19 deletion, which are the ones that are associated with drug sensitivity. She had this testing. She was found to have one of those mutations, and she started on erlotinib. And we expected a response that lasted for a while, and the cancer blew right through it. Doesn't make any sense. I mean, we found the mutation. She should be sensitive, right? And so we went back and dug deeper and tested, in addition to those common mutations, a broad panel, a next-generation sequencing panel, and also found T790M. So I would say that most testing done today, because of the importance of this mutation, are testing both common EGFR mutations as well as the resistance mutation. But you're right, you only see what you look for, and it is possible to miss this if you didn't think of it in advance.
So I have a question about going back to what we were talking about right before that question. Does T790 act the same on the cancer, whether it's acquired or germline?
Good question. Yes.
Really?
In either instance, it is associated with drug resistance. If you've acquired resistance with T790M, you're not going to be sensitive to one of these initial EGFR inhibitors. And so when I saw Joe, who will tell you her story later, I said, you know, you have this T790M in your cancer. It's not even worth trying this. This is a resistance mutation. Your cancer's not going to respond. It's a small population. It's a little hard to test. But in the patients that I've treated with standard EGFR inhibitors with T790M at diagnosis, we have not seen responses. And so it is both a marker of acquired resistance or a marker of de novo resistance.
So would it make sense, going back to your point about, you know, testing up front for T790, could you technically, if it's not on the panel that you're going out, could you technically do a cheek swab on the person to at least see if it was there at all?
We don't do cheek swabs lightly. We don't lightly think about testing the person's genes, right? When we're testing the person's genes, that has implications for your whole family. Right. That is it's like a big deal. We test tumors, and so I would say it is prudent to test more broadly. I have another young patient of mine who grew right through erlotinib despite having an EGFR mutation, and her tumor, in addition to having the EGFR mutation, had MET amplification. The patient is on the Young Lung study and is now responding to combined EGFR MET inhibition. The point is, it's uncommon, but resistance mutations can co-occur with sensitizing mutations. Looking for more genes gives you more information. That's one of the potential values.
So how did this study come into being? How did this happen?
And so because we realized that, really, what we learned is that if it's possible to find this mutation in a patient because of what's in their tumor, then we can take a condition that's very rare, I mean, really 1 in 1,000 lung cancer patients, and we can find these individuals by looking through the standard testing that's happening everywhere. If everywhere's testing and everywhere's finding these mutations and don't know what to do with them, we just put up a sign and say, if you find this, send them to me, honestly. And so with Alchemy support, we made a website and we have a video of me talking about this, and we just sort of put up a shingle and said, we will take your T790Ms. And it took a little while, but over a couple of years, people started to realize that patients like Joe, patients who have this resistance mutation, who have no drugs proven for them except standard chemo, are out there not being looked after, and so we'll look after them. And they started coming in. And it's, the study is designed to provide, really it's remote. Patients can come into the study on the web, just like the Young Lung study. I have patients from Oklahoma and from California. I have patients from Alabama. I have a lot of patients I've never met who have reached out to our team to say, I'm an outlier. I don't fit. People aren't making trials for me. I'm different, but I want to be looked after. And we look after them. And we educate them about the condition. And after they sign consent, we test them for this mutation in their genes. And some of them end up being positive. And I think the surprising thing we found is sometimes they come in with this extraordinary family history of lung cancer. And sometimes they don't even have a family history of lung cancer. It's just their cancer shows this mutation. And we end up telling them, this mutation's inherited. Your whole family's at risk. And they're like, no. And so there's so much we're learning about this as we do it, finding people that we're surprised about. So patients get genetic testing, get counseling from educated counselors at my site who have now met enough people with this condition that they can speak about it in an educated fashion and can educate. And then if they're positive in their genes, then is the moment of saying, do I invite my relatives? Do I take the step to try to encourage my relatives to now learn whether this is in their genes as well? And then we look after the relatives as they come in. And we're taking care of these families who are exceptional and trying to help them cope with the risk of lung cancer and strategies to reduce that risk.
So to the best of your knowledge, has this ever been done before? Has anybody looked into a familial link in lung cancer?
There are different kinds of familial links out there. Everyone knows BRCA and breast cancer, right? BRCA mutations in breast cancer and ovarian cancer, high risk. A high-risk mutation like that has a lot of meaning to a patient and a family when you find it. And that's why we hear about prophylactic breast surgery and all these strategies to reduce risk. In lung cancer, there has not previously been a really high-risk gene like this. There are low-risk genes. There are genes that will increase your risk of lung cancer by about 50%. And if you think about it, you know, since there's lung cancer everywhere, and everyone has a little bit of risk of lung cancer, a little bit of an increase in risk doesn't make a big difference to your life. And so we've known about these low-risk genes, but this may be the first really high-risk gene, aside from really rare syndromes like Li-Fraumeni syndrome. There are some genetic syndromes, but this is kind of an outlier. This seems to be different.
So are you looking for those low-risk genes in these people as well to see if they have all of them?
The short answer is no.
Okay.
We're trying to be very focused on one distinctive syndrome, but I think this maybe is a marker that there's more out there we haven't learned. And even if your family doesn't have this gene, the question is, wait a second, is there more to risk that we don't understand that we need to learn about? And hopefully this is the beginning of learning more about this process.
So let's just take this scenario. Somebody has an EGFR mutation, and they start on Tarceva, and then they progress. At that point in time, you could do a blood biopsy to see if they have a T790 gene.
If at that point they've developed T790M that wasn't there before, it is not in their genes, right? It is an acquired mutation. You can look, you can get a biopsy, you can get a blood biopsy, you can try to get on one of these great new drugs, but it doesn't have, it's a different kind of blood biopsy that we're looking at, right? For this germline study, we're looking at what's in the cells. What is in your genes? The blood biopsy for patients who develop resistance is looking at the DNA the tumor has released, the tumor's genes.
Okay, interesting.
Let me ask you.
Yeah.
If I can, first of all, I want to say to the lady from Clovis, I was on that trial that you had, and that is still ongoing. So I want to give that full disclosure, and it was very good. But secondly, you know, if we look 5 or 10 years down the line, and you've done a determination with your staff and with all the people who have T790M, so that a certain percentage, whether it's 1 in 1,000 or whatever that number happens to be later on, do you foresee at some point 8, 10, 12, 15 years down the line that we go in utero and correct it even before the baby has been born? If we're able to determine.
Let's go stepwise.
Well, that's why I'm giving you a few years.
Today, there exist genetic tests that any patient can say, I want to get my genes checked. Now, we can debate whether this is ethical or whether this is marketing and a scam. We can debate, fine. But it is possible all across the country for patients to say, I'm worried about my risk, check my genes for me. Do you guys think this gene is on that panel? No. Right? The first step for me is to say, we have identified a really meaningful gene that has implications about our understanding of lung cancer in general. That has implications about our understanding of lung cancer as a disease that happens based on environmental exposure, sure, but also upon inherited risk. The first step for me would be to get this mutation on those panels.
But I'm giving you 8 years.
After that, someone's got to prove, and then we have to learn about what these implications, what these mean, right? But I won't deny that decades from now, there may be strategies to improve the inherited genes. This is a little bit outside of my expertise, to be clear. We're going a little far out there in utero and stuff. But that I could envision such a future, though it might have some ethical challenges. How about before then, can we identify genes and then find ways of reducing risk? Can we then learn how to apply the tools that we have, CAT scan screening, X-ray screening? Can we apply the tools that we have to find high-risk people and reduce their risk? Can we find pills that can prevent cancer from developing? I think those things will happen in the next 5 to 10 years before genetic engineering of embryos. Problem.
This is what happened because I went to Foundation Medicine last Thursday.
Okay. Maybe they have a 20-year time frame, maybe, but I don't know.
Andrea, did you have an online question? Whoops.
Okay, and then I have a personal question, but I also want to hear Joe and Nancy's story.
Yeah, we're going there next.
There's 3 questions from online. Can Dr. Oxnard address the high prevalence of non-small cell among non-smoking Asian women?
Lung cancer in non-smokers, I've said this before, is the 7th most common cancer worldwide, independent of lung cancer in smokers, right? Lung cancer occurs regardless of environmental risk. And non-smokers' lung cancer can occur in smokers and in non-smokers, right? There exists risk beyond our current understandings. When a patient comes to see me, do you know what risk factors I ask them about? As an oncologist, right? All I see is cancer patients, okay? When I see a patient with lung cancer, what risk factors am I interested in? Smoking. That's it. It's the only question I ask. It's because our understanding of risk is so rudimentary right now that nothing else impacts my management. Even that, you wonder, right? Genetics beats smoking now. So it's like, maybe I don't even, if I have Foundation Medicine, I can just test their genes and skip the smoking question, right? So the point being that our understanding, I think, is too basic. What we need to be able to do is better quantify the diversity of complex things that can impact lung cancer occurring, and those include some inherited and some environmental and some that are bad luck. I do not know why non-small cell lung cancer seems to be occurring in, who are the people again?
Non-small Non-smoking Asian women.
Non-smoking Asian women. My guess is that lung cancer is happening to everyone, and we are just trying to understand differences in these populations, but I don't know why. And there may be an inherited risk that we do not appreciate.
I just want to tag on to something that he said before you go to the next question. So if smoking history is the only thing you ask your patients, is it because the answer to that question is going to somehow dictate what your follow-up or your?
It's
I
not
mean, I
the
don't
only
know.
thing.
No, I know. I'm just curious.
I collect the history, but it's the only thing that we quantify right now. Because
I don't think you're
pack
alone in that.
years,
That's why I'm asking. Yeah.
the number of years smoked cigarettes does impact our understanding of genetic risk, right? And that there are some kinds of genes that are more common if you smoke more, and some kinds of genes that are more common if you smoke less. Heck, maybe these new immunotherapies have differential activity depending upon smoking history. It is one of those basic biomarkers that we ask.
So the answer
because we can measure it and we've learned about it, but like, I fill out a survey, I do not even know how to ask about marijuana.
Yeah.
And people say, don't even put it down there because it's like illegal for someone to answer. And so everyone just says, never mind, I don't know, don't put it on the survey. What do I do about radon? Was there radon in your house? I don't know. Should I go back to where I grew up and check? No, never mind. Just skip the question, okay? We don't even, like, it's like people can't answer the questions and in such a way that I can use the data. And so so I think there are complexities that we do not yet appreciate. And hopefully with the digital age, we can better collect this information and learn from it.
Makes sense. Okay. Go ahead.
Next question.
Okay. Now, this is an online question, so it might not make sense because it's not really making sense to me, but I think you'll get the gist of it.
Sometimes they don't translate right, yeah.
How do you determine a genetic connection when a father with small cell adeno passed away in 1992, a mother with small cell adeno in 2008, and then a daughter was diagnosed with small cell adeno in 2013 at age 29? Where do we go to see where the connection is?
Non-small cell.
Small cell.
Oh, small. Is that what she said?
Small cell.
That's complicated. So how many patients in this room have a family history of lung cancer? Anyone in this room have no relatives with lung cancer?
That you know of.
It's not that uncommon to have relatives with lung cancer, okay? How common is lung cancer? Common. One of the problems is that this is a common disease. This person that we just heard about had a father and a mother with lung cancer. To be clear, the father and the mother, I presume, were unrelated. Right? And so like you can only
They're calling now.
You can only get your genes from,
Right.
unless this person got a high-risk gene both from the mother and from the father, or maybe they just got a big dose of bad luck from both. The truth is, for an inherited syndrome, we would expect to say lung cancer on one side, not on the other side. Oh, I see association in these genes. And so I think this might be, the hard part is we don't know. We don't know if this person just has a lot of bad luck in the family or something inherited. And you're right, I can't parse that. It's terribly complicated.
Or could it imply an environmental situation such as radon?
And it could imply that you lived in the wrong state. I don't know what, honestly. So it's very complicated is the short answer to this question. It's very hard to parse what part of that risk, very clear risk, is inherited versus environmental versus chance. It's scientifically extremely difficult.
Okay. Well, I'm going to ask.
It needs a lot of people to answer that question.
Okay, but I'll ask a personal question based on my family history.
Yes.
So Bonnie, diagnosed in 2006.
3.
No, 3. Good Lord. Her mother was diagnosed about 9 months after that. And then when my grandmother passed away, not from lung cancer, we found my great-grandfather's death certificate, and we had just thought he just died of old age, died of lung cancer.
But Grandma's sister did, too.
Grandma's sister, let's just put it this way. There's a lot of lung cancer on Mom's side of the family.
Maternal side, yeah.
But since she doesn't have a tumor or a tissue, when she was diagnosed, they didn't biopsy, they didn't test, they didn't do anything. What do you suggest besides, I mean, Danielle and I, and, well, not my brother, but we've all had CT scans. You know, it's not funny, but we all say, okay, who's going to be the one who's going to get diagnosed? Yeah. And my theory is I'd rather be diagnosed at an earlier stage than, I guess bottom line, what do we do?
How can a person worried about risk reduce their risk? How about that? Okay. Perfect. So let's first quantify risk. Lung cancer risk is currently measured in one very standard way. Guess what it is? It's the same one I just mentioned, smoking. I hate to say it. And you know why? Because we have surveys, we can count the numbers, we know how to ask about it. It's very quantifiable, okay? And in individuals deemed to be at high risk due to a history of smoking more than 30 pack years, which means a pack year for more than 30 years, a trial called the NLST, National Lung Cancer Screening Trial, looked at screening CAT scans versus x-rays and found that getting a CAT scan allows you to identify cancers earlier and reduce the risk of death from lung cancer. And therefore, in patients with high risk based on this metric, this one metric that we all agree upon, it is now indicated to undergo CAT scan screening. Okay, so if we can identify risk, if we can quantify risk, we can do something about it. It's not easy. The NLST was a huge, long trial, but the process starts by identifying risk, quantifying risk, and then doing a trial to study risk reduction in those individuals.
But do you see with the INHERIT study, the future of the INHERIT study of, you know, maybe T790M being somewhat similar to the BRCA gene?
The idea would be, can we make this quantification of risk more nuanced? All right, and the answer is yes. Now that there's evidence that we can do something about it, right? Now that we know that we can actually reduce people's risk by the right intervention, CAT scan screening, low-dose CAT scan screening, there are a lot of people motivated to make this risk quantification more nuanced, to incorporate things like other inhaled substances, or environmental exposures, or radon at the home, or family history, or genetic alterations, some low risk, some high risk. Mm-hmm. And there's a lot of work now trying to turn risk into a more complicated model that looks at the whole person and not just this one number scale over a number of years. And so it's happening. It's currently happening. And it's happening by epidemiologists and statisticians and pulmonologists trying to make risk a more complicated metric. If you can quantify risk, then you can intervene. And I believe that in the years ahead, we will agree that inherited T790M is just as high risk as 30 pack years of smoking and should have CAT scan screening indicated. But the onus is upon us to prove it, and that's what we're working upon.
Exactly.
And this is just one, I think, of many risk factors that over the years ahead we will identify because we're motivated by the fact that CAT scan screening works. Now that we have something that works, right? Now that we have the mammogram for lung cancer, we need to find who should get it. That process is underway.
So Geoff,
sorry.
I'm sorry. Go ahead. I have a question. First of all, the World Health Organization came out with about a year ago that there are as many carcinogens in the air we breathe as there are in cigarettes. So table that for just a second. When do we get to the point where we test everybody for lung cancer mutations upon diagnosis rather than just smokers or people with familial, propensity?
You might get a colonoscopy at 50.
Yeah, because they don't do that for breast cancer. They don't single out certain people. And I'll back up just a little bit. The New England Journal of Medicine just came out with a couple months ago a whole new list of cancers and other diseases that are associated with smoking. Breast cancer was one of them, bladder cancer, and others, not as high as lung, but still many. So when do we get to the point where we stop talking about smoking and start giving lung cancer patients the same opportunities that colon, breast, and prostate get?
I'm going to answer the question. How many people in the room know what the BRCA1 gene mutation is? Just through a primer, if you have this mutation, there's a high chance of you getting breast cancer or ovarian cancer. And many people with this are undergoing prophylactic strategies such as breast removal surgery, ovarian removal surgery, MRI screening, mammograms if you're male. Okay, based on that brief summary, who in this room wants testing for BRCA1? Raise your hand if you want it. Exactly. My point is, I don't know if I want it. I mean, really? Do you want to test my genes? I'm not sure I want my genes to.
But they've got
it is a
all
personal
women testing
decision.
for mammograms.
Even in breast cancer, BRCA1 is a personal decision today. And it is a decision that not everyone undertakes. It is offered. It is talked about. People are aware of it. Patients are aware of it. And it is part of a comprehensive breast cancer management strategy to talk about inherited genetic testing. But it's not like it is a panacea that everyone says, sign me up. I want this. I want this. I want to know whether it's in my genes or not. And so
Probably because it's so expensive to get the test.
it's increasingly cheap, and partly because it has major implications that not everyone wants to think about. So what I would ask is, 5 to 10 years, I hope that that for lung cancer, like with breast cancer or with ovarian cancer, genetic testing of the patient's genes is part of a comprehensive evaluation of a lung cancer patient, right? And a comprehensive conversation about risk. It would be great if that risk conversation is more comprehensive than the current one, and be more nuanced. But I'm not saying that necessarily everyone on their way in should get their finger pricked so they can be told if they've got this gene or that, because that has some ethical complexities that currently we're not ready to handle. And indeed, Dana-Farber is starting this process that in addition to testing everyone's tumor with a next-gen panel, as they come in the door, we currently offer that for free. Everyone at Dana-Farber can get next-gen sequencing. They're going to also do blood sequencing in addition to better understand what's in the tumor and to better understand what's in the patient. And this is an emerging process to say, look, we should be offering this comprehensive understanding to our patients, but it is heavy stuff, and they need to know the implications of it before they sign up.
But you only offer it once they have cancer.
Well, Dana-Farber is a cancer
So I actually think though that that's a good segue into to the stories of these beautiful ladies sitting on the couch, and you know what compelled them to join the study and what it meant for you. So I don't know if Nancy, if you want to start, or Joe. Yeah.
Nancy's a pro at this.
Yeah.
Is it on? Yes, my name's Nancy Cappeli, and I joined the study about 2.5 years ago. And I came here, I think the first time I came was when you were here 2 years ago. And I joined because my mom has lung cancer, and she had breast cancer before that twice, many years ago. And when she had spots in her lung, they always thought it was metastasized breast cancer. But when one of them finally grew, you know, about 3 years ago, they biopsied it and found that it was actually not breast cancer in her lungs, but lung cancer. And her doctor, Galteri in Huntsville, Alabama, recommended she get a second opinion from Dr. Steve Carbone, who these guys know. And he was in Vanderbilt University at the time, luckily, a couple hours from Huntsville. And she went up there, and he said, this is this T790M, and it's in your inherited genes, and your kids should be tested. And, you know, so Mom told me, and I live around here, so I went to Stanford. They didn't know what I was talking about, but I got my blood tested and, you know, joined this study, the Inherit study. But I tested as positive for having this inherited gene. And, you know, there was no protocol or anything at the time. What do we do? This isn't a normal test. And so I got a baseline scan, and that was about 2 years ago. And in that baseline scan, I have these nodules. So really, by having this capability to find it this early and having a study like this, I was able to find very, very early, no symptoms, non-smoker. This is the last thing I'm thinking about. And, you know, one of them had to be, you know, a surgery and taken out. and it was stage 0. So, I listened to all these conversations and think in the future, lots of people can find out in advance and, not wait, because lung cancer, we all know in this room, you're typically, when you have some of those symptoms, you're a lot further along. So in a way, having that ability to know it's in your genes, allows me now to get, I had the one removed and I have these other little spots, and now I'm on a 1-year cadence to get this low-dose CT scan. So everything's stable, and so I'm, constantly monitoring because of that. And so if something takes off, we're going to get to it early. So I see tons of benefit in knowing this. And my mom and my brother are both also in the study. Okay?
Yeah, awesome.
So just before we go to Joe, what would it, realistically, had you not been made aware of T790 or the study and your mom hadn't been with Dr. Carbone, what would that have looked like for you, right? And how long can we say before she may have become symptomatic,
Right. So we
right?
don't know how long it takes for an early cancer to become a cancer. And it could be a couple years, and it could be a lot of years.
Mm-hmm.
So we don't exactly know how this works. And so what we're trying to do is say, we can't see the future, we can see today. And today we want to do is reduce your risk as much as we can.
Yep.
And that risk reduction is vigilance, keeping an eye on things, CAT scans, and someday maybe chemo prevention. Maybe someday we will have a pill to say, we can take your risk and bring it down. Hopefully part of describing the syndrome is to create an opportunity to just ask those questions and to do the trials. High-risk patients, how do we find that pill to bring their risk down? But I don't know. I don't know the answer of how long it would take for this to become a big problem, except that we know cancer, has a troublesome end game, and so anything we can do along the way to bring the risk down is smart.
Yeah, obviously, I'm glad we don't have to know, because what if it was 10 years from now and I got a cough or something, right? So
And the same question for your mom, for example. How long were those nodules
We don't know.
in her lungs?
We don't know. They could have been there, for 50 years.
Could have been there for 50 years. Imagine, right? And so we're really at the beginning of such a process of learning and every patient is an enormous amount to learn from.
So this is sort of identifying cancers too. This is a whole other problem, right? Cancers you can live with, right? And
Until the moment
can't.
becomes when you can't.
Yeah.
And when is that moment?
Yeah.
And how can we risk reduce
And
along
how
the
do
way?
you weigh how much scan and low dose scan do you give versus the trade-offs?
How fun are the scans?
I like to come out of those and know I'm kind of stable.
Okay, good.
So,
Right.
they don't hurt.
Reassuring. Okay. But I know, but people who hate scans, right? And to each his own. I think a CAT scan's more fun than a colonoscopy. That's a good point. Maybe more fun than a mammogram, honestly.
And it is. I'd take it over both of those.
Geoff, maybe you could talk a little bit about a low-dose CT scan.
So low-dose CAT scan. Let's talk about what an actual CAT scan is. It's a very fine image using X-rays. It's like a million X-rays all at once, trying to visualize what's going on inside the chest for a patient who's got belly pain and might have appendicitis, and you have to see very clearly. And that's a diagnostic scan, which means you really don't want to know what's going on. There is actually cancer that you're following, and you need to see if it's bigger or it's smaller. You do a diagnostic CAT scan. A screening CAT scan says, probably this patient's fine. Probably this patient's healthy. All right, and therefore, my suspicion is on the low side. I'm going to try to just take an easy glimpse in what's going on. And so it's less images, it's done more quickly, it's less radiation, and it tries to do a sort of snapshot of what's going inside the chest, hoping to get about as much information out of an X-ray's worth of radiation. So it's low radiation, trying to sort of not be more radiation than a mammogram or an X-ray. Now, I'm not a radiologist, so I can't tell you exactly how much it is compared to that. To say, let's just take a quick look at what's going on. The problem is, if you see something suspicious, you may need another CAT scan. You may need to dig deeper and get a more detailed scan. because that's what you would want before undergoing a surgery.
For example, would you recommend initially a low-dose CAT scan, or would you go on to say they should initially have this T790M if it appears to be an inherited type of lung cancer? What would be the best course of action?
If what we're dealing with is a patient with cancer,
I'm talking about
hold on. Okay. What we're dealing with is a patient with cancer, okay? You should listen to your doctor, okay? And you should get a CAT scan if they say you need a CAT scan, okay? If you are cancer-free, then you need to understand your risk. And the question is your risk high or low? And if what your risk is, one family member with lung cancer, your risk is very, very small. And you should do nothing except don't smoke. Right? The question is, what are our risk reduction strategies and what is the risk of those strategies? There's not a lot of risk to not smoking. Generally, it's a good way to have better luck. Smoke is a good way to have bad luck, and not smoking is a good way to have better luck, okay? So not smoking is an easy risk reduction, but then as you start getting into CAT scans or blood testing, you're starting to say, is the risk of my intervention more dangerous than my actual risk is today? We do not right now quantify the risk of people who are not 30-pack year smokers. 30-pack year smokers have enough risk that you should do something. People who have less risk than that should count their blessings and invest in better lung cancer research.
But may I interrupt one thing here?
Yes.
I'm good at interrupting.
Please.
I was in the ALCF, and
Yep.
I was a smoker, I'm sorry to say, for 30 years, but I had quit over 15 when I entered that. They lost, where I was getting the CAT scans done, the low dose, they lost the funding, and we were told that we could pay for it ourselves at the rate that insurance would, and if we got an RX, or whatever you would call it, suggested by our primary care. And I went to my primary care, and he said, no. He said, I don't want you to have any more radiation. And I said, this is so prevalent in my family. If it can be found early, I would be willing to risk that, getting the extra radiation. And that was the year, they got funding, but that was the year that my lung cancer was found. So I think each person has to decide what their risk is and what risk they're willing to take.
And preferably, we, the medical community, can help inform that and can come up with a better riskometer that includes things like family history. It doesn't right now, right? And that is a deficiency of our current understanding of risk. But I think that's evolving, and I think we will be getting there, where if you're a patient who's had a 20-pack year smoking history, but you're 20 years out, but you have 2 parents with lung cancer, you know, we can say, wait a second, there's some risk here we're not measuring correctly. This is a person who deserves a CAT scan. But I do think the data is still catching up to get there. And I can't right now recommend it, except to say that there are people who are high risk that we are missing. I think that's true. And if you think you're one of those people, go talk to your doctor and advocate for yourself, because you're right, you might find that you're an outlier who needs to be studied. But at the same time, you may have less risk than you realize, and I want you to be reassured. And I can't right now measure everyone's risk because my riskometer is just too flimsy.
That's why I'm saying you have to be the advocate. If you feel you're at risk and you're willing to take the chance. I'm so thankful I did it because I had no symptoms.
So if somebody had T790M like me and they tested positive, would you recommend they have a CAT scan?
Sort of like some people I know, yes. I'm recommending CAT scans for patients who have T790M inherited.
Yeah.
Because we have patients in their 20s who are spots in their lungs, right? We're seeing things. We have some patients who have it who have nothing, though, who are clear. And we don't understand why it is.
T790M.
But have clean chest X-ray, clean CAT scans. But we are seeing a lot of young lung nodules, and I think the earlier you know what's going on, the better you can follow and measure the risk over time.
Know, like, Like, were mine there at 20? We won't know, but if you have a lot of other people at 20,
Then you can figure out
see
what's
it.
new and what's old. Right. How young? We struggle with that.
Yeah.
But currently the study only takes patients who are adults, have to be 18 or older. A parent cannot order testing for their kids because the kid needs to be able to consent to this independently.
So Dr. Oxnard, another study you're closely involved with is the Genomics Young Lung study that is collecting the ability to look at the germline in patients in a research environment. Do you want to address that for a second?
So right, another outlier condition. If you're young and you have lung cancer, is this because there's something in your genes? In that study, we have 1, maybe 2, still, even in young people, not a lot of them with this inherited syndrome. The question would be, is there another inherited syndrome that causes lung cancer in patients under 40? And so we're going to try to test more comprehensively to figure out if there are other genetic changes that explain this young risk.
Do you have online questions? I saw you.
I do, but I have a personal question. I'm always baffled. So, I go in for my yearly exam, and I'm, touched all over my boobs, and I have nobody in my family that has breast cancer. And I've already had a mammogram. I fill out the little paperwork, and it says, family history, and it's lung cancer, and then it asks you who. And they don't ever, do you think there's ever going to be a, checkbox?
So what you're saying is they don't ever guide you beyond that?
No, but what's the difference between me having to get a mammogram, and now it's not every year, but it's, every few years, with no family history versus me getting a low-dose CT scan?
Maybe you shouldn't be getting a mammogram.
No, I know, I agree.
I mean, so you're right. But I guess 10 years from now, I mean, CAT scan screening is really new in lung cancer, right? So I hope that it will gain momentum and be that kind of thing that everyone's talking to their doctor about. But right now, it's not. I think mammography might be an example of where it goes too far and where people are getting mammograms. I mean, I have patients who are dying of lung cancer who are saying, oh, I'm sorry, I can't make my appointment with you today. I have to get my mammogram. And I'm like, you don't need a mammogram. Come see me instead, please, okay? So where it's gone a little bit too far, and that's because of a successful education strategy to make everyone know that there's something we can do and we can reduce the risk of breast cancer. And so where's our education strategy, right? This is what's on it for us.
Exactly. Don't you think what's going to happen is rather than more people getting lung cancer screening, less people are going to be getting mammograms and PSAs and colonoscopies? Because if you look at where genetic testing is going, we all should know at some point in time what we have a propensity for, and we can get the appropriate screening rather than screening for absolutely everything that's out there.
I hope we can have the momentum that mammography has, right? I hope we can get out there and become the thing everyone talks about. And I think we can, but it's going to take what we're doing right now, which is making it clear that lung cancer risk is more complicated than we appreciate. I want to hear from Joe.
Yeah, let's hear from Joe.
Well, my family history sort of addresses all of this. My brother was diagnosed at 45, non-smoker, a routine chest x-ray diagnosed him, and the whole family was in shock. He ended up dying at 47, left a family of 3 kids. And we all went through the gamut of, okay, was there radon exposure? Was there asbestos? You know, we tried to figure out where did this come from. Well, about 5 or 6 years after he died, my mother was diagnosed with lung cancer.
Age of 80, right? 80
she
years
was
old?
80 years old when she was diagnosed. Now, this part of my history is a little unclear because she said that they had been following nodules for years. We never heard about it. We're not really sure about that. But she had a wedge biopsy, diagnosed adenocarcinoma, and then decided to do nothing. She basically had a breakdown from having this diagnosis of cancer. She couldn't mentally handle it. So after a year or so of her diagnosis, my second brother decided he was going to get a CAT scan. He was very nervous and wanted to know if this was a...
What age?
Let's see. He was probably 40-something. He was getting close to my brother's age that was diagnosed. So when he had a CAT scan, it came back abnormal. He had multiple nodules, too numerous to count, throughout both lungs, and had a freak out. The ironic thing is I'm a cancer registry manager and have a lot of connection in the cancer world, and I have colleagues that are oncologists and surgeons, etc. So I'm trying to help him get consults and whatnot from having the abnormal CT scan. So I thought to myself, I never, ever felt that I was at risk. But I thought, this is a little weird. Maybe I should get a baseline CT scan. So I did, and lo and behold, I had multiple nodules throughout both lungs, spiculated nodule in the lower left lung, and had my own total freak out. So I ended up having a wedge biopsy at that time, and it was adenocarcinoma, but minimally invasive. I think you were at the pathologist, you were working with the pathologist about the time that I had my initial diagnosis.
Oh, Dr. Travis.
Yes.
Yeah, who evaluated your case, right?
Yes, and this was in 2010. So I, let me get a drink, my mouth is dry.
I was in New York at that time, and I was getting started on this whole research project.
Right, nobody knew about any familial genetic lung cancer. So they took out the wedge. They did 5 different sections of my right lung, and everything came back with the BAC, bronchoalveolar presentation of adenocarcinoma.
And that surgery was where?
That was done at a community hospital in Maryland, where I live. Don't recommend go to a...
Anyway, moving on.
Okay.
Yeah.
So I ended up going to U of Maryland initially, and up in Baltimore, and I went to an oncologist there, and basically decided I had the EGFR mutation, but nobody knew anything about T790 at that point. It was, just no connection, no knowledge of this might be a link to lung cancer risk. So I decided with my doctor there that if it's stable and nothing is happening and you got the nodule that was growing, I'm not going to do anything except have surveillance CT scans, which I had for a couple of years. In the meantime, because of my connections at work, I ended up transferring my care to NIH, which again, I was stable. Nothing was growing in my lungs, so I went ahead and let it lie. The beast was sleeping, I like to say. So about, I think it was winter 2013, a nodule started growing. So I ended up having to have open thoracotomy at that point. They took out my left lower lobe, did a mediastinal node dissection, I think 22 nodes. One node had cancer, the one nearest the tumor that was growing. So I did have some nodal involvement and thus had to have a subsequent round of chemo, cisplatin and vinorelbine, which was no fun, no picnic. Lost my hair, but it gave me 10 months of stability. And 10 months after I had my chemo round, I had another problem. The lymph nodes were lighting up, and they decided to see if I was eligible for immunotherapy,
L1.
Yeah, PD-L1. So to get in that trial, I had to have a MRI brain, and the worst day of my life was when it was discovered that I had multiple brain mets. And nobody would, and I had not a symptom. I have never had not a symptom. So that led to whole brain radiation, which was probably worse than the chemo as far as long-lasting, brain damage, I call it. So my doctor at NIH laid out what my options were. I had another round of chemo, standardized treatment, a trial for the immunotherapy, or Dr. Oxnard's trial, which was because I had T790. I thought about it. I went and saw Dr. Oxnard, and I said, that is where I need to be. That is definitely, I felt like, where life was leading me.
So can I interrupt for a moment?
Yes, please.
Most patients with EGFR mutation, in order to get one of the new resistance drugs, need to first go through a round of the standard drugs and show they have resistance. And need to first go through a few months of erlotinib or afatinib, and the cancer grows. And you're at the point where you're like, just went through treatment, you're like, look, I don't want to start with a drug that's not working. I want to start with a drug that's working. And it just by a loophole, the AURA trial of AZD9291 had a first-line cohort of patients who had not had prior therapy for metastatic disease. And since you'd had prior chemo for adjuvant therapy, by this loophole, you were able to fit under this arm of the trial. And therefore, you weren't exactly what they were thinking of when they made the trial, but you fit. And this is the way trials work, right? They make a box, you got to fit in the box. And so you were able to get on this trial of AZD9291.
Right. And it was initially, when I started taking AZD, it was a hard road for a couple of, about a month or two, but I feel great. I am stable. I had shrinkage. I'm a stage 4 lung cancer patient that is living with cancer. And I have immense respect for the research that goes into this, and feel that we need to educate and the public and everybody else, this is the killer. Lung cancer is the biggest killer. It kills more people than the other big ones, prostate, breast, combined. The other thing I wanted to mention is that I have a big family. I have the germline mutation, so I offered it to my children to be tested. I have 4 kids. 2 have tested negative. They don't have that mutation. 2 have the mutation. And one of my kids had a CT scan which revealed a nodule and a little ground glass, which, was very faint. So it kind of addresses the whole. My brother died from very aggressive cancer. My mother lived until she was 86, and she just died this past summer of lung cancer. And then I've got my child who is basically very early, and I feel that this is giving him the opportunity to catch it from the beginning and manage it and survive. I've always told my kids, and there's a big thing about, I don't want to know. I have, my brother he has not been tested for the mutation, even though he probably has it. But people don't want to know. And I've always told my kids, knowledge is power. And I feel it's very important to learn as much as you can and, fight. So.
Joe, what message would you want to leave with the people in the room and the people that have dialed in?
Well, first off, I would say don't make the word cancer such a scary word. I mean, you can live with this disease. I mean, you can live with it. And I remember Dr. Oxnard has rules. And I think I really took it to heart. And his 3 rules are don't lose weight, which I did lose weight, but
you look good.
That was the number, but I'm maintaining now, I'm not losing. Don't act sick, and don't be a martyr. And by that, I think I take it to mean you advocate for yourself, you learn what you need to learn, and you go forward and live your life, and you don't give up.
Thank you. And thank you for sharing that story. That's amazing. And also very encouraging for a lot of people that are
Can I
watching
tell a sidebar on this story? It was a scary moment when I first prescribed this pill for Joe.
I think my question to you, if you remember, was, well, am I going to drop dead on the spot when I take this pill?
So this is an inhibitor of T790M. And every cell in Joe's body has T790M. And so the question was, are we, in trying to find a pill that's going to make her cancer behave, are we also going to cause devastating toxicity to the rest of her body? And Joe was the first patient with this inherited mutation to ever try one of these pills. And in fact, the first month was hard, and it was scary, and I was like, oh my gosh, what am I doing to her? She felt fatigued, she felt nauseated, it seemed like maybe something terrible was happening. It turned out that her brain radiation was causing swelling, and she took some steroids, and she got better, and it was not related to the pill at all, actually. And now she's one of 4 patients I've been involved in who have received drugs like AZD9291 or other drugs with a germline mutation who have not had dramatic toxicity. And this is important. This means that this pill is an option for patients like this, both to treat the cancer and I envision someday maybe to prevent these cancers from occurring. And that's a really amazing idea. If we talk about 5 or 10 years from now, this seems like a pill that's aligned with the biology for cancer, and could this be used to prevent cancer someday? That's a maybe. And the first step is to understand and to show that it works, and to get the drug approved, and then we can start playing with it.
So is it approved now? Or?
None of these drugs, the AstraZeneca drug, the Clovis drug, the Astellas drug, the Novartis drug, there are a lot of drugs in development. None of them right now are approved. They're all investigational, but they're all under review. The Clovis and AstraZeneca are under review.
But that's a good segue into clinical trials, because you can get the drug in a clinical trial.
Right.
So if you're out there and you have these issues, talk to your physician about this subject, and if not, contact us and we'll get you in touch with somebody like Dr. Oxnard, if not Dr. Oxnard, that will make sure you get them.
Clinical trials can be a pain. Joe flies to Boston every 6 weeks to get her scan, right? I mean, you can say, oh, it's an inconvenience, but it is an opportunity at the same time. And you really, if you want to make a trial an option, you have to put yourself out there and show up and say, what is out there for me? It does require motivation to try to make your case fit into a case that the clinical trial is looking for. And for Joe, it just sort of was very fortunate that the wording of the trial allowed a unique person like her.
So Dr. Oxnard, in terms of clinical trials design, you mentioned Joe has to fly up for her scan. Is the future of trials, we talk about bringing the trials to the patient. Is there a future where patients can be treated locally, still be in a clinical trial, but not have to necessarily fly to Boston or to New York or whatever every 6 months for an evaluation?
There are the trials where we learn from patients. These are correlative trials, tissue trials. There are trials where we can ask interesting questions very broadly. And I think that with the Young Lung study, we are showing the ability to bring people together from far parts and bring together this rare group and yet assemble them in this virtual space to learn from. That's very, very cool. But a treatment trial is a little different, right? To give an investigational drug, for me to have sent the script down to Maryland and said, good luck, let me know how it goes, no. Right, so with a brand new drug, investigational, you really need the person in front of you. And I'm not convinced, I mean, how the drug is dispensed, the pharmacy, the nursing, it's so complex. I think it's still gonna be a fair ways before we deliver first-in-man drugs to a patient from 1,000 miles away. No, that requires a lot more hand-holding. I think there might be an in-between. There might be a way of doing some kinds of trials more remotely. The National Cancer Institute is trying to bring smart trials to every cancer center everywhere, right? The Master Lung Trial, which is every single cancer center, community cancer center everywhere in the country. The Alchemist Trial, which I'm involved in leading, adjuvant targeted therapy to every center everywhere in the country. Right? We are trying to take trials and deliver them. But first-in-man studies, I mean, the Aura study was a phase 1 trial. The first 100 people in the world ever get this drug. You kind of need to show up and bring your A game and say, am I a candidate? And we can't really do that remotely.
Well, that's kind of what I mean by don't give up and fight. That if you have the opportunity to participate in a trial, if there's any way for you to do it, do it. Because I think that's how we're going to cure or manage this disease.
And the first step of that is get a second opinion. Just ask, say, hey, is there some cancer center I could go just for an informational visit, right? There are plenty of patients I meet once and I say, you got a great doc, you're on track, I hope I don't have to see you again, right? But other patients I say, you're different. You know, there might be something you're not thinking about. I'm glad you came in, let's go with this, right? And the first step is to say, you know, is just it's so easy, just pick up the phone and call some cancer center and say, can I come in just to have one conversation to find out what's out there? Yeah, come on in.
There's some online questions. I see your papers piling up.
Yeah,
No.
got a journal over there.
There's online questions directly for Joe. Somebody wants to know what else you do besides treatment. Do you diet, exercise, supplements?
I don't take any supplements. I don't diet. I try to eat healthy, but I'm not on any, weird diet. I eat a lot of chocolate.
Chocolate's good, I hear.
Grandkids? Dogs?
I have grandchildren. I have 5 grandchildren. I do try to work out. I try to walk. I walk my dog 2 miles every day, try to. And, I try to live a healthy life, but I don't do any of the, mega vitamins or any of that stuff. I don't do that.
You take your chemo pill every day?
I take my AZD. And my biggest fear was during the winter, with all the stuff going on in Boston, that I wasn't going to be able to get to Boston to get my AZD. Because
I think they would have got it to you.
Well, it's not like they can call CVS and say, but it worked out.
Okay, one more question for you, Joe. How old were your kids when you had them, when they tested for the mutation?
Well, their ages now, and this has all happened in the last couple of years, 30, I'm going to get it wrong, 34, 32, and they were negative. Then I have he was 29, he's 30 now, and 24, and she's 25 now, and they were positive. They had the mutation.
So Dr. Oxnard, you once said that it's about a 50-50 chance, correct, of passing it down?
If you have the mutation in your tumor at diagnosis, we think it's about a 50-50 chance that it's in your genes as well. If you are a first-degree relative of someone who has the mutation, it's about a 50-50 chance. On the study, we are testing first-degree relatives, 50-50 chance, second-degree relatives, 25% chance, and even third-degree relatives, 12% chance. And so we can test more remote relations, but the more remote your relationship, the lower the risk.
I have one more question from online. There's a patient on the East Coast. I'm EGFR positive, adeno, progressed on Tarceva, tested positive for T790M through blood test. Can a blood test be as reliable as a CT scan for my 2 children in their mid-20s?
I'm going to presume this person responded to erlotinib and acquired resistance. This person has T790M in the tumor and not in the genes. The blood test is not the same kind of blood test. It's not a blood test of the person's genes. It's a blood test looking for the tumor genes, I think. And so it's a little complicated answer, but send me an email. I am using blood tests both to look for the tumor's mutations. That would be so cool. If we can actually figure out what the tumor's thinking by following the floating DNA in the blood. But I also use blood tests to sometimes, in a different way, test the person's genes. If you have acquired T790M after Tarceva or after afatinib, you do not, this is not in your inherited genes, and you don't have to worry about your kids.
Interesting.
Well, so we're going to get an email.
Penelope has a question. Yeah, hold on.
So at one point, an oncologist had checked my mom's, he was surprised that supposedly she was T790 negative because she had 2 sisters with lung cancer, but apparently she was. So is there any chance that if you get a negative T790, does that mean I probably wouldn't, do we need to dig deeper? And then when her 2 sisters passed away, they didn't know about T790. So no test was ever done. So my cousins are wondering, what can they do? can they be tested? Should they just, we got bad luck, or what's going on?
The existence of this syndrome makes us think that others might exist. If you have a striking family history like yours and testing that shows no T790M in the tumor, assuming the testing was adequate, and I can't assume that, but I would be happy to talk to you in more detail. The question would be, are there other even more rare and even more unexplained and elusive processes going on? So there are, in fact, 2 other mutations in EGFR that have been described as inherited, and a mutation in HER2 that's been described as inherited. Now, given how emerging this data is, that data is even less impressive. But I think the possibility of there being other alterations, it's real. And I would say the first step is potentially to do more comprehensive testing of your mom's tumor. I know that sounds complicated, but it might be possible. And that would help to understand really if there's some other signature that we could try to focus on and think might be an alteration that would explain all this. And if we can't, then we need to wait for science to catch up and appreciate that sometimes it has to be explained by chance. But I agree that yours is a family that needs to be studied more.
I have a question. So your Inherit study is enrolling well, but there are mechanisms probably out there and people out there that could participate in the study. What would you say to them on why they should participate in this study?
If you feel like you are an outlier family that people are not understanding and not appreciating, if you have multiple family members with lung cancer who didn't smoke, I think that is going to be the kind of people in this family, though I don't know. And certainly, if they did smoke, I think testing a tumor is the most fundamental first step. And if you are someone who has T790M and it's not explained, we want to look after you. And you need to come in. And I know that's a rare population, but they're out there. And if you feel like your doctor doesn't really get that you're different, come our way. Everyone should get testing, and everyone should be thinking about what could be different about my family. And if you have questions, we have a website, danafarber.org/T790M studies, and we can answer your questions. You just send us an email.
And we have 2 patients on the couch, survivors, who can attest to the value of this for themselves and for their family members.
Absolutely. I have a question for you. With all the talk of smoking, the young kids today have these e-cigarettes. What do we know about them?
We need to understand risk better. You're right. And we believe that they're probably not as bad as conventional cigarettes. If at its basis, bad luck causes cancer, I don't think e-cigarettes cause good luck.
Right.
But I don't know more than that. And it's just emerging. And I do worry that we are going to be seeing a rash of strange conditions from e-cigarettes about 10 years from now. And yeah, I think it's a problem.
Right, because
I don't condone them, if that's what you're wondering.
because the young folks nowadays, with these medical cards that they have for marijuana, are smoking out of these e-cigarettes too, which is quite worrisome,
I recommend chocolate over e-cigarettes.
Thank you.
I actually have one more question for you to put it out there. The physical sites, the places patients can participate in the Inherit study are?
Currently open at Dana-Farber in Boston, Vanderbilt in Nashville, Tennessee, and Ohio State University. And those are the sites where we have physicians and trained counselors, but also remotely over the website and where it all can be done. You can spit in the specimen, spit in a cup, and you can send it to us, and we can do the counseling over the phone.
So in other words, you don't have to go.
You don't have to show up,
Boston
right?
Or, yeah.
I only see Nancy when I come visit California.
Right. Yeah. So you get on Alchemy's site, and it'll tell you what to do.
But I will not
as
visit.
well,
I can't promise I'm going to visit all of you, though. I only visit Nancy.
So how many people are you looking to enroll in the study?
We have 50 patients. We want to get to 100.
Okay.
and that includes individuals and relatives. We have, almost 20 different families involved now. Some bigger, some smaller. Joe's is one of the biggest.
And the importance of this study, or the nexus of this study connected to the Clovis compound and AstraZeneca and others, could be what?
Yeah, that this drug, if we can identify syndrome, if we can identify a small population and they can get a pill and both treat their cancer or prevent their cancer. I mean, what an amazing opportunity to now have a medicine that could potentially be used as a chemoprevention. I think that we start here and we work towards that place. But to show that cancer risk can happen to all of us, smoking or not, it could just be in your genes, and we're trying to show that today.
Do you have any idea or best guess right now about what percentage of the population we're talking about that will be affected by this?
Around 1 in 1,000. Real but rare.
Yeah. But Geoff, when we talk about those numbers, and when we look at the underserved that are never diagnosed, and people that die from this cancer that were never even registered or treated anywhere, that could be as high as 40% of the total number. Realistically, what could it be?
I think the possibility of inherited risk is greater than we currently appreciate, right? And that and I hope that CAT scan screening and the ability to do something about this will help us figure out what those risk factors are, right, so we can make a difference.
Right.
But that process is beginning, and
right,
it's too slow,
right,
and it's underfunded,
right,
and it's understudied.
Right.
But smart studies that combine cancer genetics with inherited genetics aren't happening and need to happen. Right. And those studies are just getting off the ground now.
Yeah.
And what's interesting to me is this study came to us, actually. We didn't know Dr. Oxnard. Dr. Carbone actually was approached by Dr. Oxnard for ideas on funding sources for the study. Dr. Carbone referred the study to the Bonnie J. Addario Foundation, and it just ended up being this perfect nexus of a funding organization stepping in with the consortium to help power it.
And the study would not have happened without the Addario Foundation support and the support of the ASCO Foundation as well.
Yeah. And just to touch on, for that 1 in 1,000, I mean, it's to that one, it's a home run. So, and who gets to say who gets to be that one? That's just one of those,
And I think it is the beginning of a better insight into risk. We were going to say, okay, people stop smoking, but lung cancer is not going to just go away, right? This is still going to be a problem that we're going to be having, and the complexity grows. We need to understand it better than that. It's not this a simple fix, no more e-cigarettes. It's not going to change this.
No. And we talked a little bit about in the beginning that pie chart. I know we've showed you that in some of our living rooms, and it's also in our patient handbook, right? Is the chart in there? Regardless, it's a pie chart. You've all seen a pie chart, and what this is it has the known mutations and markers for lung cancer. And there's KRAS, which is a real big one, and then there's EGFR and ALK fusion, and it just keeps going. But then there's this big section that says other. We don't know. We haven't discovered them yet. So
it's going to be made up of little slices.
It's going to be
lots of little slices that we add up together.
Just like the one we're talking about tonight.
But the little slices accumulate, and 10% of lung cancer. If we get 1%, that adds up to a big chunk of people. Understand those little slices will help us make a difference.
And in lung cancer, just a few percent is a big number, because lung cancer is a big disease. So that's our goal. We want pieces of the pie.
I ask doctors, when I give talks about this pie chart, I say, how many people in this room has seen a mesothelioma?
Right.
It's like rare, but it's a cancer people see, and everyone raises their hand, oh, I've seen a mesothelioma.
Right.
How many people have seen a Ross rearranged lung cancer? No one raises their hand.
Right.
They are equally as common.
Exactly.
2,000 patients a year in the United States have mesothelioma. 2,000 patients a year in the United States have Ross mutant lung cancer. It's just they're not looking for the Ross mutant lung cancer, so they miss it.
And isn't it also true that we believe that some of these mutations, EGFR and ALK and ROS, are like, I don't know, 17 to 20% of lung cancer markers.
Oh, adding it all up, they make a big chunk.
Right. So all that being said, if we get to that underserved market and get them tested and into treatment and into clinical trials, I think we can find that that's actually a much bigger chunk.
And I think this what gets also to liquid biopsies, or to, you know, if we can find an easier way to get people tested, then we can get them to drugs, and then we can get them treated.
Exactly.
Right. But this is why the message of don't get the test is so important.
Right.
Everyone needs their tumor tested.
And in fact, to put a plug in for Dr. Oxnard, he just published a paper in Nature Medicine two days ago, and it does discuss liquid biopsies, and that has a future.
I printed them out for all of you, so anybody who's interested, please take them home. Dr. Oxnard.
I have one more online question. A son or daughter is asking a question about his mom. My mom is responding to Tarceva. Can she get tested for the T790M mutation before she develops resistance?
Excuse me, I'm sorry. It's a good question. So, in my patients who develop resistance to erlotinib, if they feel fine, I don't rock the boat. This is a marathon. The goal of this is to do this as long as possible. And if you're feeling okay and you're tolerating the drug, I don't go asking questions where I don't want to know the answer. So I have patients who have early resistance and they just hang in there for months, sometimes years after resistance develops. I generally tell people, do a liquid biopsy to look for the resistance mutation when you have resistance and when you're thinking of doing a needle biopsy. Because liquid biopsies do not always work. If you find it in liquid, great, you can act on it. If you miss it, you have to go on and get the needle biopsy. And so I hold off. There's a lot of debate there. But it is possible, perhaps, to find this mutation early on and switch. These days, you need the biopsy to find the mutation to get you on the trials. So I would just wait for another 6 months until we have more headway. If you're responding, don't rock the boat. That's my quick answer. Good question?
Well, no, so let me just, so then if they're responding well to Tarceva, then just
enjoy it.
Enjoy it.
Enjoy it.
Go eat chocolate.
Okay, a lot of chocolate, Mother.
All right. And tolerate it, right? And bulk up, because the moment will come when resistance develops, and that's when, but like the longer you do this, you know, science moves ahead of you and gets better and better, and the treatments get better and better, right? And so I would put that time in the bank, use it well, and figure there's going to be a more complicated moment down the line when you might need chemo, when you might need immune therapy, when you might need targeted therapy. All those things are mights in the future, but the longer you can hold off, the better we get at it.
You know, Dr. Oxnard talked about outliers earlier in the evening, and what outliers are they're like super responders, or even the opposite, people that don't respond long on a particular drug. But we want to find out why they don't respond a long time and why they do respond a long time. We have a patient who started coming to our living room 6 years ago in tears. Not you, but remember when you first came, not too long ago? She was in tears. Well, she's been on Tarceva 6 years now. She doesn't even come anymore, and we're glad we don't see her. She'll be back if she recurs. She's living large and she's enjoying her treatment, and do that. Be happy with what's happening if it's positive, and keep searching and keep looking if you're not in a positive situation.
Yeah, and it's also about ensuring, you know, that the physician who is treating you, you know, be empowered and educated enough so that if and when the time comes that you do resist, you can either bring something to the table for him or her, or he or she is already going to know what the best next step is.
If you're responding, it's our job now.
Right.
Yeah.
To work on the next steps.
Yeah.
Right. So you can just invest in us, and then we got to pull through.
Yeah.
And that I tell my patients that it's like, you know, this part I'm doing my part. You just wait. There'll be your time to work hard down the line when we need it.
That's right.
So I want to kind of close the conversation around Inherit with a little bit about maybe you talking about the plans to present some findings at ASCO and how big a deal that is. And
yeah, we submitted the science as an abstract at the American Society of Clinical Oncology meeting, which is coming up in June. Submitted not to the lung cancer group, but to the genetics group, to the people who talk about risk. It was selected for an oral presentation, which is really exciting, and I think a big moment.
What's an oral presentation?
What's that?
What's an oral presentation?
Which means I get to stand up in front of hundreds or thousands of scientists and explain the results, which is very exciting, and I think a great moment to tell people what we're doing and to notify these people, right? And again, all these people are saying, why don't people realize this is out there? Right. This is that moment to spread the message. And so I think we've, I guess I got to get my slides together and bring my A game.
This is a really big deal, though. I mean, it's a very competitive space, right? Yep. To be accepted for an oral at ASCO. So why do you think you were chosen?
I think this is new and different, and people. I'm sure people say, wait, there cannot really be a high-risk lung cancer syndrome that none of us know about. But yeah, it's out there. And so the time to spread the message, and hopefully we will follow this up with a publication soon thereafter to tell the community what we're doing and to get people motivated to move this even further along.
Yep. That's good stuff. Does anybody have any other questions before I move on to? Go ahead, Essie.
When I had surgery in 2003, they did not give any chemo before surgery or anything, so I never had any of that. Do they do it now? In other words, do you get chemo first before they do the surgery to kill whatever might be in there? I had stage 1 bronchoalveolar.
For low risk, for stage 1 cancers, adjuvant therapy is not standard. Surgery on its own is curative and is the best we can do. For higher risk cancers that have spread to lymph nodes, additional chemo is done, and we're studying targeted therapy beyond chemotherapy, and that's the ALCHEMIST trial. And currently, anyone who's undergoing lung cancer surgery for their cancer can enroll in the ALCHEMIST trial to get genetic testing and see if targeted therapy can help chemo be better, but not for stage 1.
And Dana-Farber was the only place that did testing for mutation at that time. No one had it. Stanford didn't.
In 2003, it had just been discovered.
Yes,
so it was just the beginning of the process.
Bruce Johnson asked me to tell Stanford to send the block to him, and I did have a mutation. I can't remember. It was a regular, was the first one you mentioned, Geoff.
EGFR?
Maybe that was it. What I do, I don't concentrate on anything unless
Don't worry about it. If you're cured, you don't have to think about it.
I'm not cured. I have many spots. And I have to take a CT every year. And that gives me radiation, of course. And is Stanford up to date on everything nowadays?
I know the docs at Stanford. They're great. They are definitely on top of this.
Are they on top of things?
Definitely.
Because you mentioned 3 other institutions, and I
know them personally. They're doing a great job.
Okay, but that's where I've been going, and I don't know. In the past, like I said, I just went all over the country.
I think you're in good hands.
Okay,
Geoff, one generalized comment for you to make to the group. It's not just about EGFR, correct? Do you want to talk about, in a minute, just all the other mutations that are emerging and the drugs that are associated with them and what's following behind in a minute?
He has a little longer than a minute.
I do think the EGFR story, which has been a 10-year story, is the beginning of a much more complicated one. ALK has been now 5 years or so, ROS 3 or 4 years, but BRAF and HER2 and RET and TREC and KRAS and MEK and NRAS and on and on and on. Yeah, there are more and more of these. There's just new ones being appreciated this year, or a couple new ones being talked about at ASCO this year, right? So the process of discovering signatures and finding drugs for those signatures is always ongoing. And when I have a patient who seems to be an outlier, but seems to be negative on testing, I push forward further. We have this we have a blood test developed where we've been able to find things sometimes that aren't seen in the tumor. So I think the search for a genetic signature is the search to connect a patient with an opportunity. It doesn't work for everyone, but it is a process that we're learning more and more about. But there's dozens and dozens now, some that have drugs, some that have trials, and some that are still a mystery.
I don't even know what EGFR is.
Each of these is a mutation in the cancerous genes that causes it to go, that explains its growth.
And that's what they found.
It is the driver gene, but it means in patients with metastatic cancer, an opportunity for a targeted therapy, and maybe that's a targeted therapy that can also help earlier stage therapy in the curative setting as well. But right now, it connects patients with metastatic cancer. A genetic alteration links to a treatment opportunity.
Yeah, I just had surgery.
Grab a mic, you're good.
Is the EGFR mutation, does it also drive other types of cancer or just lung cancer?
Lung cancer is I think, ahead of the pack here. Different cancer types have other genetic signatures that are being looked for. In melanoma, it's BRAF and NRAS. In colorectal cancer, it's BRAF and KRAS. Lung cancer, we've made the biggest splash. I think other cancers are catching up right now with this process of linking genetic signatures to drugs.
I think it's important to note, too, that lung cancer has made a huge splash in a subset of the disease, right? Because we're not talking here about small cell, not even about squamous at the level, right? Mm-hmm. So there's still a ton of work to be done across the board. Does anybody, we have about 5 more minutes for talk time. So does anybody have just general, questions about lung cancer?
Doctor, you mentioned the chocolate a couple of times. I know you may not be that serious, but in general, for the cancer patient, do you have a recommendation on diet? What kind of a general food you should take more than versus others? Yeah, that's
I think that living with lung cancer is living with risk and the possibility of an unexpected rainy day, right? When you have lung cancer, you can get a blood clot or a pneumonia or a stroke or a seizure, and these things that you didn't think were part of your life suddenly become a possibility. And that means I think you should be living with 10 extra pounds saved away for a rainy day, honestly. So I recommend calories to my patients. I recommend grandkids and calories, the good things. Moderation is fine. I am fine with a little bit of alcohol. I am fine with, I prefer not smoking because I don't think that's good for you. I'm fine with supplements and I'm fine with alternative diets if that's what you like, as long as you don't lose weight. So I tell my patients, once you've gained back the weight you've lost, then you are welcome to try any alternative diet you wish. But I say chocolate merely because I mean that calories are important and are needed because the cancer can steal calories from the body. And so trying to maintain your weight is a way of trying to maintain reserve in case you have a setback. Is that different than what people have heard?
Not here.
Okay.
Yeah.
But we
It
don't
is a
really
big
know.
question.
And there are other cancers where diet's more important. In colon cancer, they're much more, they've studied diet a lot more. Just in lung cancer, we don't have as much data to say one way or the other. And certainly my patients who eat chocolate do at least as well as my patients who don't.
It is a big question, though, nutrition. I mean, patients come all the time and they're like, well, should I stay away from sugar? Should I, you know what I mean? Cancer feeds off sugar, so I shouldn't eat sugar. And patients ask all the time. And see, me.
Weight loss is dangerous. I know that much. And otherwise, all I know is that being pleasantly plump gives you flexibility in case you get pneumonia.
I lost 20 pounds in about 10 days when I was in the hospital in Stanford. But I'm putting some on now.
I recommend cheeseburgers for that.
Okay.
Well, and I think it's important to note that the problem, because we see it happen all the time, is that the weight loss and the malnutrition can actually become worse than the cancer itself, right? A bigger
and then
problem.
if you don't have that reserve, even an easy pill can be very, very hard. You need to have that reserve. You need to have some meat on your bones. You need to get up and do stuff. The 3 rules, just to remind you, Joe, are don't act sick, all right? Don't lose those that muscle weight, all right? Don't let yourself, you gotta be able to get out of a chair without using your hands, okay? That's the proximal muscle strength is so important. Don't act sick, don't lose weight, as we discussed. The 3rd one is don't be a tough guy. Don't tough out your symptoms. Don't stay at home saying, oh, I feel miserable, I feel nauseated, I don't want to call the doctor, I'll see him in 3 weeks. No, then you're going to get sicker. Call the doctor, complain, speak up, tell them how you're feeling. Make them take care of you. This is oncology, this is not primary care. You can't be a tough guy. Those people do poorly.
Dr. Just thank you, because my mom's been on the fence about a second opinion, but I think we just got it today, so thank you.
One more question. Anybody have a question before I go to housekeeping? Everybody's perfectly good. You don't have any questions about your cancer? Okay. So housekeeping. So first of all, yay and thank you to Dr. Oxnard.
Pleasure, thank you all.
And to Joe for coming out, and Nancy and spending their time telling us your stories. Thank you so much. Some of the housekeeping, like we always do, I want to, of course, reiterate some of our upcoming events. We have a run in Saratoga May 24th, our golf tournament. There are a few spaces open if you know anybody who likes to golf. June 1st, I'm looking at Andrea. And then our Chicago event's June 7th. So if you have any family members or friends in Chicago that you think might want to come out and have some fun and raise some money, that's a good time. You can pick it up.
And there's also an event in, it's not working, in Connecticut. Tricia and Kathy.
Yeah, there you go.
There we go. We also have an independent fundraiser who, this is the second year that they're doing it. It's country themed this year. Last year it was pizza.
Yeah.
But with pizza and $48,000 they raised, yay.
A pizza party.
With
yeah,
pizza.
Not bad.
But this year it's in Connecticut. Stephen, what city?
It's in Wilton.
Wilton, Connecticut. Tricia and Kathy. But you can go on the website.
Mm-hmm.
They're welcoming everybody, so it's not a closed event.
Yeah.
Do you also want to mention what you're doing in Denver?
I'm really excited about that one. Hold on. So we were invited to a World Lung, which is International Association for the Study of Lung Cancer. It is where everybody in lung cancer comes and will be there. But we were invited to do an event. I expect that Geoff is already registered for that and is running that morning. But it's unique because we're inviting all these physicians from around the world that are specifically focused on lung cancer. And we're also inviting the patients to come out there and run. And whether that means traveling to Denver or just running virtually, anything. But we're excited to partner with ISLAC. Or walking.
Yeah.
Well, it's a walk.
I think
Dr. Fred Hirsch wanted to do a fun walk, so it's about a mile. So it's not a run. I mean, I think I can even run a mile.
I think it's important to note one of the coolest things ever is that ISLAC agreed to partner with us, not just on this, but on a couple of other things surrounding World Lung. It's the International Association for the Study of Lung Cancer. Andrea mentioned it first, so which is why I stuck with ISLAC. But and this fun run that we're doing is the day that the meeting opens, and it's actually part of the registration process. So as all these docs from around the world are registering, they have to cross a path before they get to the end that says that we're partnered and this is happening, and I think that's really awesome. So
Geoff has an abstract there too for both.
And you don't have a mic.
And there will be 6,000 to 7,000 people from all over the world, all working on lung cancer under the same roof for 4 to 5 days, which is amazing. And we'll all learn a great deal.
Can you say anything about that?
Yeah, sure. We can talk. So you guys all know, if not personally, I'm sure you've seen her, Emily Bennett Taylor, and she's actually keynote speaker at the opening of ISLAC. So she's going and she's going to talk about us, which we love because we want every patient to have access to wonderful things like this, where we've got some key opinion leaders coming in and talking to you guys and donating their time, by the way. We get them, we get them here. They don't have to pay to come, but nobody yet has asked us to pay them to be here. They do it out of the kindness of their hearts and because they believe in what they're doing. So, so we're really excited about that. So Emily's doing that, and then you're on a panel there too, correct? Yeah, we are. So we've got a lot of, and we're actually trying to do a remote living room there too. So it's a little crazy. Yeah.
But the beauty of this year of the International Association for the Study of Lung Cancer, by having asking Emily to be the keynote speaker to open World Lung, is a huge shout out to how things are changing. I don't believe a patient has ever opened World Lung, and I don't believe advocacy has ever been this involved in a World Lung Cancer meeting. So it's really good news. It's good news for patients. It's good news for foundations like ours. It's good news for Geoff and the research he's doing, and for everybody involved. So they're exciting times for lung cancer. So we should close with a great deal of hope that there's many, many good things coming down the road.
Yep, yep. I want to give a shout out, obviously, to some of our sponsors: Merck, Lilly, Novartis, BMS, Celgene, Genentech, Astellas. Without their literal financial support, we would not be able to bring this to you guys. So we're very, very appreciative to them for allowing us to do this for you. Obviously, a big shout out to Peninsula TV for coming. And for those of you that live here that don't know, Channel 26 is local cable TV, and Penn TV not only comes out here and films this for us, but they also play it on local cable over and over throughout the month. And you forget something that Dr. Oxnard said, you'll be able to pick it up on Penn TV. And then to the Office Bar and Grill for the food. Huge thank you to them. Another huge thank you and round of applause to our panelists. Thank you all for signing in. If there's anybody that speaks Spanish, I am going to be in Hollywood, Florida next Tuesday for our very first ever all in Spanish living room. And it's about multidisciplinary care, so it's kind of going across the board with these great docs spearheaded by Dr. Luis Reyes out at Memorial Cancer Institute. So we're really excited about that. So if you're interested, click in through the Ustream and you can watch. And then Dr. Lori Gasper from University of Colorado, Denver, is a radiation oncologist, and she'll be here May 28th for our regularly scheduled programming. So, yeah. So. No, she's not. And we're off air, so we're just kind of talking freely right now. But I'm terrified. I don't know how this is going to go. I talked to Dr. Reyes the other day, and I just thought, oh, you know what? How are we going to work this? I'm going to need somebody on the floor like telling me what everybody's saying up there, so I can interject with questions when need be. But I think it's going to be great. They're a great group out there. So, and they've got about somewhere 60 or so patients all lined up and ready to come and sit in the room and participate. So I think it'll be cool. Yeah. So thanks, everybody. Thanks, everybody online for signing in, too. And thanks to Jenny for moderating, since Andy was on the couch tonight.